So in the interest of being exactly on time, which we are, we seem to have a quorum, and Bill has asked me to introduce Dr. DeCampli, who absolutely needs no introduction. And all of you know of his reputation and abilities. But what you don't know is what a pleasure he is to work with and how productive he is. So without further ado, Bill's going to educate us about some aspect of statistics. And I confess I don't know where that's going from here. Bill?
Thanks, Dr. Williams. Let's see, I'm going to share screen to start my talk. So Sunita, are you on board?
I'm here.
Okay, just in case, you should confirm that you're seeing this once I get it going.
Of course.
Thank you. So do you see my blue background screen?
Yes.
Okay. And you should see the slide now, right?
I do. You're good to
Okay.
go.
Okay, perfect. Let me just test one other item. Okay. All right. Okay, so as I said earlier, Dr. Blackstone usually gives this talk. I cannot in any way hope to compete with his always very insightful talks. Nor can I talk for an hour, so I won't. But I thought I would still stick with the general theme that has been traditionally used in this hour, and that is a discussion of some aspect of statistics. So I have no disclosures for this. I hope you'll find this sort of a combination of being amusing, but also carrying some serious tones or admonitions to it. It's meant to be pitched in a very positive way, but does present some real challenges as to how our brains, as rational as we try to be, end up behaving. There are a lot of novel and advanced statistical methods that I could talk about today, and that would take hours. And some of these are listed here, and some of these we've actually utilized in our data center work over the years. But they are very complicated, and it really makes you wonder about statisticians. It reminds me of a very short story. There were two cardiologists and a statistician hunting bear in the woods. They see a bear in the distance. The first cardiologist raises his gun, fires, and a bullet passes to the foot to the left of the bear. The second cardiologist raises his gun, fires, and that bullet passes about a foot to the right of the bear. So the statistician drops his gun, raises his hands up and says, "We got him." Well, anyway, one of the disadvantages of webinars is that you can't hear a audience reaction. And I wonder how comedians perform over webinar and get that satisfaction that they depend on normally so heavily. Well, in any case, what I'm going to do is go back to basics. Instead of all the complicated stuff, let's just play a few mind games today and appreciate that, guess what? The human being is not good at reasoning with uncertainty. Given this, we need to be very careful and critical about how we design studies, how we analyze data, interpret the results, and apply the conclusions. Now, this is not a downer discussion, but a reminder that we're empowered to detect and avoid the fallacies and other gremlins that might otherwise infiltrate the difficult types of research that we undertake in our field. So what do I mean by problems with reasoning with uncertainty? Consider this what you might consider the simplest problem in probability. You toss a coin 99 times, and the first 99 times, it happens to come up heads. What is the probability that it will come up heads on the 100th toss? So again, in a live audience, I could easily poll you or hear reactions, but what is your answer? So if you're taking Stat 101, the answer is 50-50. And, you know, the teacher will appreciate your understanding of the fundamental law of independent probabilities.
Why isn't it, Bill, why isn't it 99%? Because it's a biased coin.
Yeah, well, Dr. Williams, didn't you review my talk before today's presentation?
Oh, did I comment too early?
Well, if you're a betting person, the probability is, of course, nearly 100%. So Dr. Williams, in his infinite wisdom, is right again. Because you know what? That can't be a normal coin. And you had better use that knowledge to place your bet. Now, this argument and its implications in how we think and work is actually cogently discussed by Taleb and is dubbed the Ludic fallacy. So try this one. You do a series of coin flips and record the results, okay, heads or tails. This is just a sample of what you might get, as I've written in red here. So this is a string of coin flips. The question is, how many flips does it take on average to first see the triad HTT appear? Okay, so think about that. Well, at first glance, so let me give you an alternative. How many flips would it take for you to first see the triad HTH? So at first glance, your brain tells you that there's something more unusual about flipping two tails in a row, you know, getting that HTT. So you think it will take more flips to get HTT than it would to first see HTH in a random string. But then you realize that the chance of flipping 3 times and getting HTT is actually the same as the chance of flipping HTH. So the chances must be equal, right? Alas, your original hunch was correct, but for a more subtle reason. The chances of seeing any sequence of any length depends on the nearest neighbor flips, not just on the flips in your prescribed triplet sequence. So this is not entirely intuitive, but it's absolutely true. It's actually a simple cluster analysis type of problem, and it's very relevant in gene sequencing. Again, your brain is playing tricks on you. Here's the famous prosecutor's fallacy, and I'm sure many of you have heard this. A woman is on trial for murdering her 2 infant children. The defense claims they died of SIDS, sudden infant death syndrome. The prosecution scoffs, saying that the a priori likelihood of both live babies dying of SIDS is exceedingly small. It's in fact about 1 in 2,000 births. So therefore, the probability to have 2 such babies both die of SIDS must be about 1 in 4 million. Very, very low. Ergo, the babies are much more likely to have been murdered than died of SIDS. Is all this true? Well, the defense is a former Kirkland Ashburn fellow who unfortunately didn't stay in congenital heart surgery, but became a lawyer. But because of the mound of statistics that this person learned, the defense says, but the babies are already dead. The correct logic, therefore, is to calculate the probability that 2 dead babies died of SIDS. Now you need a different number. You need to know the type of mortality among babies that die. And about 1 in 10, or 10% of babies that die in infancy, die of SIDS. Therefore, the probability that 2 babies in the same household die of SIDS would be about 1 in 100. So you get about this 1 in 100 chance that this was the cause. On the other hand, there are statistics that show that the probability that a dead baby was actually murdered as a cause of death in this country is about 1 in 70. So the chance of 2 babies simultaneously being murdered is about 1 in 4,900. And so the defense finishes by saying that clearly it's much more probable, by over a factor of 50, that these babies died of SIDS rather than being murdered. Our motivation for discussing these fallacies is the theoretical argument here by John Ioannidis and the subsequent empirical evidence that a substantial percentage of findings reported in our medical literature are probably false. There are many papers since the year 2005 corroborating this evidence. The company Amgen tried to replicate 53 so-called landmark studies in cancer research and could only reproduce the results in 6. Florian Prince then reported in Nature Reviews Drug Discovery that they could reproduce published results in just 17 of 67 seminal studies. While I don't have time to replicate all these studies, in my role as one of the deputy statistical editors for JTCVS, I have found significant statistical gremlins, I would say, in about 80% of the papers that I review. So how does this happen? We begin with so-called truth inflation. Stated simply, it's the observation that significant or positive results reported in the literature will likely show greater effects than is the reality. The causes of truth inflation are many, but include the so-called base rate fallacy, which I'm about to discuss, ignoring inadequate statistical power, publication bias, explicit or implicit use of multiple comparisons without correcting for them, and finally, inappropriate use of stopping rules in clinical trials. So I'm going to consider a few of these. The base rate fallacy is really interesting. First, this is, I think, amply represented by the following example. A test for a disease gets the correct answer in 99% of the time. Okay? A random person tests positive. So what is the chance the person actually has the disease? So your quickest answer, 99%? In general, it's not 99%. Nor anywhere near that. Let's, instead of explaining that, go to another example. A study of bleeding after the arterial switch operation, actually published. A prospective randomized blinded study with designed with appropriate statistical power to achieve these type 1 and type 2 uncertainties. There are 2 groups. One received a drug designed to decrease bleeding, and the other group placebo. And the outcome measure was simply to measure transfusion requirements. So it was a good study design, an RCT with adequate statistical power. The drug was found to be effective, and the authors concluded that there was only a 5% chance that this was a false positive result. In fact, the drug reduced transfusion requirements by 11 cc's per kilogram, or about 25% in this study. The conclusion is incorrect. Here is why. Over time, there have been many investigations of drugs or other single interventions to reduce transfusion after pediatric heart surgery. We know that. Let's just say there have been 100 such proposed interventions, and they're represented by these boxes. But only 1 in 10 have been shown to be effective, okay, shown by the blue boxes. Now, is this relevant knowledge? We're just talking really about sort of a meta-analysis or an accumulation of not present, but prior knowledge. Well, of course it's relevant. We all know the inherent difficulties in demonstrating the effectiveness of any single intervention in reducing bleeding after cardiac surgery. And there are many hidden factors we still don't understand about the phenomenon, and they plague every study we attempt to do. So this again is called prior knowledge, and it can't be ignored when you're doing analytics on your own study. It's called the base rate of effectiveness, okay? So the base rate of effectiveness of any intervention using this sort of meta-analytic technique is 1 in 10. Now, of those 10 interventions that actually work historically, we know from our study design that we have the statistical power to detect that effect in 8 out of 10 of such studies, because that's how our own study was designed. Additionally, according to our p-value, among the 90 studies in which there is no real effect, or the white boxes, we will falsely detect an effect in about 5 of them. That's the p-value. And there are the 5 falsely detected results. Okay, thus, we will detect a significant effect in 13 trials, purple plus pink, and 5 of these will have not actually a real effect. Therefore, the false positive probability is not the p-value of 0.05 or 5%, but is instead 5 divided by 13, or 38%. Most of us fail to consider the base rate realistically, and some of us ignore it entirely. Like the student and the coin, we assume an a priori probability of another drug working as being 50%. We assume no prior knowledge, and therefore it's a coin flip until we get started. The 99 coin tosses 5 minutes ago told us otherwise. And these tosses are equivalent to us searching the literature to see how the gamut of drugs and all other interventions to control bleeding have fared. So in other words, P, the p-value, is the probability of seeing an effect in the population of drugs that have no true effect. But the more realistic probability is the probability that there is no true effect in the population of drugs in which I saw an effect. That is the better measure of how much you should mistrust your positive result. Well, the challenge is, how do you assign the base rate to your study? There are two major problems with this. One, there are usually not enough interventions tested to determine it. And number two, negative results are less frequently published, so the denominator of the base rate is also not well determined. So let's move on with more problems with truth inflation. So here's an RCT to determine if regional perfusion during arch reconstruction improves renal function as compared to circulatory arrest. So the outcome measure was the percentage difference in creatinine at 24 hours post-op. Straightforward study design. There were a number of prior studies dating back to the 1990s showing typical differences of around 20%. So let's assume that that represents the true difference, given that it came from a collection or a body of studies. The authors of the new study found a difference of 45% with a p-value of less than 0.05. This is a published study, by the way. Based on the p-value, they judged they had only a 5% chance that this result was a false positive. However, on review of the paper on post hoc analysis, we found the study to be powered only to detect a difference of 40% or greater. But we argued that's not great statistical power, but the authors said that since they found a difference that was larger than that, they thought they were free and clear. The difference really is 45%, they said. Well, no way. It turns out that when you have a weakly powered study, there's always some chance, as I show on the vertical axis here, that you will measure a difference of 40% with a p-value less than 0.05, when the true difference was only 20%. Now, in this example, that probability, because it's off pretty much toward the tail, is fairly low, but in typically smaller studies we see in cardiac surgical literature, that can be substantial. So while the authors said, wow, we found a big effect and it was statistically significant, the statistical editor said, wow, this study was incredibly underpowered and the result is probably wrong. So this is a cool phenomenon, actually, and it's greatly underappreciated. In short, whereas we usually consider statistical power, or beta, measure the risk of false negativity, inadequate power can also influence the chance of false positivity. Well, there's the third form of truth inflation that I earlier listed, and that's publication bias. That is that positive findings are more likely to get published than negative findings. So I'm not going to go through all the socio-political reasons for this, but you have to think that this phenomenon gives us a really warped sense of reality with broad manifestations. For example, imagine an effect it has on the veracity of meta-analysis, or on determining an accurate base rate, as I mentioned earlier. In my survey, I found that 84% of pediatric cardiac surgical papers reporting study results reported positive findings. Only 16% reported negative findings. These are probably typical positive to negative ratios. Well, I'm going to finish with just a couple more gremlins. First, Simpson's paradox. Some of you have heard of this. So here is a study comparing the incidence of residual VSD in two approaches to tetralogy of flow repair. It was a single institution and, for the most part, a single surgeon retrospective observational study. here were the results. The overall results showed a slightly lower incidence, 18%, of residual VSD with a transatrial repair. Okay, so transatrial repair, a little bit better. Well, the authors felt they wanted to be a little more sophisticated. They thought they had enough, large enough N to divide their population into two age groups. Was there an age dependence on this kind of effect? And so they did so, age less than 3 months, age greater than 3 months. And here were the results. There was a higher incidence of VSD in the transatrial group for age less than 3 months. Well, the author said, since our overall results showed the opposite, that must be made up by the results that we're going to get by looking at the other age group, the group greater than 3 months old. But here were the values. In that age group also, the transatrial group had a slightly higher incidence of residual VSD. So the authors were confused, maybe you are too, and they called us in the editorial office. How do you get one result in a combined cohort, but get the opposite result for both halves of a divided cohort? What should they conclude in their paper? Which approach is really superior? And by the way, there was no arithmetic error here. So the trick lies in the unequal numbers of patients in each subgroup. And here is your problem of having unequal group sizes. This can arithmetically give you a paradox. It's not an arithmetic error, but it gives you a paradox. If the patients had been randomized and the groups were more similar in size, one would not very likely have seen this paradox, and the conclusions would have been more straightforward. Without that, guess what? There is no way to take any combination of their data and resolve the paradox. And the authors, therefore, concluded that there was no truly valid way of recommending one approach over the other. This is called Simpson's paradox. Watch out for it. And finally, a lot of our studies lack a priori models to which to fit data, right? Typically in our field, we're looking for associations, and the most common way to do that is we fit a linear model. In fact, we'll transform variables in order to insist on our model ultimately looking linear. But remember, we don't know if the real model is linear. For example, here's a data set, all right? And if you don't know what the underlying relationship is, you would go ahead and fit some sort of linear model to the points, and that would look something like that. Well, that's okay, you can do that, but look carefully at the measurement error in this particular experiment. So there's the error bar for measurement error. You see how small it is. That indicates that the authors could validly fit a more complex model to the points. And so they did, because they weren't just ordinary biomedical researchers, they were astronomers. And these data represent the periodic motion of a star moving periodically toward and away from us. Why? Because it's being pulled upon by its nearest neighbor, which is not another star, but a planet. So this turned out to be supporting evidence for the existence of this planet. If they hadn't had a model in mind, if they didn't think that, okay, binary system, therefore gravity alternately pulls away and pulls toward the observer, they would have defaulted to a linear relationship, which just represents the motion of the Earth itself orbiting the sun over that whole, basically, quarter of a year period of time. Well, the planet, by the way, is called Proxima b, and it actually, relative to its star, Proxima Centauri, lies in the so-called habitable zone, which we've been very interested in with regard to looking at potential for life in other systems. So the habitable zone is where there's actually liquid water, and so therefore the chance that that planet could harbor statisticians in the least. So my final recommendations, okay? Admittedly, our brain does not reason well with uncertainty. What can we do to mitigate the flaws? First of all, don't trust your knowledge of statistics unless you've formally studied it. SPSS is not a textbook of statistics. It's a program with a bunch of drop-down menus that give you very short, brief summaries of what each thing does, but it's not really sufficient to tell you what you should be using. Consult a biostatistician and do it during your study design. Don't wait until you're doing the analysis. Don't hand them a bunch of results and expect them to do anything meaningful with it. They need to participate in the study design because that's what's going to limit your ability to discover what you're trying to discover. Encourage the publication of negative results. Negative results are important, as we now know, to cumulative knowledge and the redirection of research. Publish your source codes and publish your raw data so that reviewers and editors may check your results. And finally, encourage replication of studies. This is challenging, but I refer you, for example, to the Stratos initiative as an example of how the research community is responding to this need. So this is Richard Feynman, a man that I have always revered. He's a Nobel laureate, and I had the pleasure of being one of his colleagues at Caltech for 2 years. A remarkable intellect who said, "We've learned from experience that the truth will come out. Nature's phenomena will agree or they'll disagree with your theory, period. And although you may gain some temporary fame and excitement, you will not gain a good reputation as a scientist if you haven't tried to be very careful in this kind of work. And it's this type of integrity, this kind of care not to fool yourself, that is the noblest of qualities to which we should aspire." So that's the end of my monologue. We can take questions and comments.